it. Hello, everyone. Thank you all for coming. We are delighted to have two speakers from Urology department today, talking about a very important topic in pediatrics. We have Dr. Santiago. He's joined CIDRA in January 2018 as a senior attending physician. He was formerly the chief of pediatric urology division in King Faisal Specialist Hospital and Research Center in Riyadh, Saudi Arabia. After his graduation in medical school in Argentina, Dr. Vallaciani moved to Italy, where he developed his career in pediatric urology as subspecialty of pediatric surgery. He has a special interest in genitourinary reconstruction and minimally invasive surgery. Dr. Santiago published over 50 papers in peer-reviewed journals and more than 100 Congress abstracts. His interest covers also research, either clinical, basic, or public health, and received international awards for that. Medical education is another area of his interest, with faculty position in Al Faisal University in Riyadh and currently as Assistant Director of Pediatric Urology Fellowship in CIDRA. He is active internationally with participation as invited speakers in meetings and visiting surgeons. So we are very delighted to have to listen to him today. Together with him, we have Miss Ananda Nunes. She has recently joined from Brazil. She has done her training and her master's in Brazil, following which she worked as urotherapist in CDMI Center in Brazil, and she's currently joined the urology department for as a urotherapist, and she's also a physiotherapist in pelvic floor, correct? Welcome to the stage. It's all yours.
Thank you very much. So we'll do this share presentation talking about how the bladder works, and good and bad, and how can we assess it, and which is the best way to treat them. So happy to have with us Ananda as well, that is helping us with all this management that is very time consuming, as you know. So we don't have any financial disclosure, but we have another disclosure to do. Unfortunately, we come from two countries that are very close one each other. By the way, after this picture was just after we beat you. So we want in this presentation to define what is the normal bladder function, how are the tools, which are the tools that we can have for initial management, initial assessment, sorry, and to try to develop a first plan of its management. For doing that, we need to understand how the bladder works. How does it work, Ananda?
Okay. First of all, it's important to understand the normal child, okay, and how that works. So here we have some basic things, okay, about, yeah, keep going.
Yeah,
about fetal voiding, they pee every 30 minutes, so they are always with the diapers full. The neonates, the frequency that they pee. So with 6 months, they start to have high volumes with less frequency of void. And with 4 years old, they start to be with the full bladder control, okay, as an adult we expect, that is a normal one, okay. So with 5 years old, 15 and 80% is still with, not with enrices, like bedwettings. And 7 years old, 10%, the kids is still with the bedwettings and emotional problems. So always 5 years old, it's one special number, but after 7 years old, we need to take attention of these patients because they start to have emotional problems.
Yeah, and this is very important what you said about the first ones, that the neonates and the small babies are not incontinent.
Yeah, they're not.
They are high frequency, but they are not leaking urine constantly. And this is a very important thing, because when we talk about the bladder, what is the bladder? Why the bladder is there? Bladder has three main functions, that is to store the urine, to hold it, and then to empty in a controlled way.
Exactly.
And we like to think the urine as urinary system as a river. And you have these two sources coming from the kidneys, and they stay in this dam that holds the urine. And at some point in their life, in the day, I'm sorry, happens that the gates of the dam open and it empties completely. How does it? What are the elements that we have? The anatomical elements.
Okay, basically we have the detrusor, that is the bladder. So always when you say detrusor, we mean the bladder. The internal sphincter that we don't control, okay, and the external sphincter that we control by the pelvic floor muscles, okay? And that's something that I go inside because the pelvic floor is something that initiate the flow, okay? So we cannot, it's not a choice, control the internal sphincter, but it's a choice to control the external sphincter. That's why the urotherapy is important at that moment. So basically, we always ask, like, how much is the capacity of this bladder? The basic one is these numbers. So you always take the age plus 1 and multiply for 30 mLs. And you're gonna discover what is the number of this bladder capacity based on her age or his age, okay? And always, sometimes we see the poise voiding volume and we never know exactly if it's a high poise voiding volume or it's not. So we can calculate 10% based on the bladder capacity for the age, okay?
So these are the anatomical elements that we have. And then we were saying that how they work, how they interact together. So we have first the storage phase and the voiding phase, and they have to, it's like a dance. They have to work together. And these are the elements involved in this.
Yeah, okay. So let's just think about the first image, okay? The moment that the bladder is getting full, so we need some basic thing. The detrusor need to be big, relaxed, and the sphincter and the pelvic floor need to be relaxed, need to be contract, okay? So take the idea of this first image on the, on the right. And here, let me just.
No, they won't see.
Okay, they're not gonna see. Okay, so just take a look here. They can see the mouse.
Yeah, I think
so.
yes.
Here is it, the detrusor is relaxed, and here the pelvic floor is contract, and the internal sphincter is contract too. And it's important to the low pressure maintain. Okay, so the pressure on that moment need to be low. Okay, if it's high, obviously you're gonna have some reflux or incontinence. And the opposite side, you have the moment that the kids decide to pee. So the first of all, when she sits or he sits in the toilet, they relax the pelvic floor muscle, the external, and then they contract, they open the internal sphincter and the detrusor contract, okay? If the pelvic floor doesn't relax, you're going to have high pressure and can have reflux for the kidneys.
Yeah, you were anticipating a little bit what happens then in the two ages. And we were talking about this difference between the automatic that we anticipate before and the voluntary. And in the clinics, I used to go like this. We say, this is the automatic and this is the voluntary. So what happens is that when the bladder is full, the automatic opens. And this one holds. We go to the toilet. And when we reach the toilet, we decided to open it. But if we go more in detail, what means it's voluntary mechanism, there is a sequence. It's a chain of events that has to happen. So when the bladder is full, send a message to the brain, and it's a signal. Then the signal is perceived by the brain. Bladder is full. The message arrives to the brain. And then this has to be followed by an action. The child has to go to the toilet and relax the muscles. And this will trigger as well the bladder to contract more, to complete the contraction and empty completely the bladder. And then we go back to square zero. And if they don't work together, you can have the list of these things.
Or more than this.
Or together mix.
So this is the main point. So when you have patients who have urgence, okay, so go running to the toilet, it's a suddenly feeling or incontinence, you always need to think that it's continuous or intermittent because it can be anatomy problem. Okay, they can feel pain during the moment that they are peeing, or the flow, how is the flow is, how is the sound, is continuous or is interrupt? Because can be a dyssynergia, can be a pelvic floor during that moment. Okay, holding maneuvers. So you have some pictures here to see what is the kind of holding maneuvers. We have the dancings, they can cross the legs, they can hold. We have the hesitation. Sometimes they sit in the toilet and take a long time to start to pee. And also the constipation, that is one of the main points too.
That's true, because any of the moments and any of the events that can happen in this circle, the signal perception, action, and bladder function can be altered specifically, and they will have different kind of symptoms. So if we have a late signal, means that the signal arrives to the brain late. When the bladder is already full, the child has to run, otherwise starts to leak. If the signal does not reach the brain, you have a bladder that does not work. So you will have like a lazy bladder, we call it. Or if it's a false signal, that means the signal arrives, but the bladder is not full, and you have a small amount, you have what is called the unstable bladder, or one of the elements of the unstable bladder. While if you have an alteration in the perception, this can be related to comportamental, that means the child received the brain received the message, but the child decides, I don't want to hear it, or can be because he didn't achieve it yet. A month, 3, 5, 6 months child does not have the skill to understand that this signal is actually reaching the brain, or it can be a problem in the action. So you see the dancing child is classical. Stay in the iPad there, and you see them dancing, or watching TV and dancing because they don't want to stop doing whatever they had to do. Or can be the opposite. A child that goes very frequently. On stress situations, sometimes happen even to us adults, that we go very frequently to the toilet. This can happen even more for the child, and you may need to understand what is the source of the stress. Can be even the toy broke. You say, but why? But for them, it's a very important moment. So you need to become a little bit psychologist as well. And it can be as well incoordinate. Usually related to the holding the urine, this can become then a fight between the bladder and the sphincters. And the bladder itself can be altered as well, together with other or alone. And you will have what is called the detrusor thickening. So the bladder is thicker than usual because it's used to contract. And this can lead to leaks and pain. And this can be primary or secondary to the previous three we spoke before. On top of this, we have our friend, the bowel, that can mess up whatever is happening. So we need to think in both things at the same time, because the constipation has a role. And we don't know exactly why, but these two things go together. Usually, you have a child with a problem of constipation, look into the urinary tract. You have a child with a problem in the urinary tract, look to the constipation. They come together.
Yeah, and that can happen because we have the same embryology, we have the same pelvic floor. They share the space. Okay, so when you decide to hold, when you contract the pelvic floor, to not make the stools, you're gonna hold the urine too. When you hold the urine, you're holding the stools too. So they are combined. And one important cycle is when they have pain, they decide to hold. When they hold, it's going to be more dry, they're gonna have more pain, and it's a circle that you never break. So you need to go directly for the constipation. So here we have some image. Imagine like the full of stools making all the pressure into the bladder. Okay, so you're gonna have some effects on the bladder, or the opposite too. Okay, and you have the bristles to have a reference how is the stools are. And it's really important to say it's not just the quality of the stools, but the frequency and the things that they eat. So you have to ask many things, not just show the picture and ask how is the quality. Okay.
And this is an example what can happen, what you can find in a child that is severely constipated. What you see there is the bladder that is compressed from posterior wall because of the presence of the stools. This is something that you have to look for, and you have to look in the images. Rarely you will find a radiologist reporting this, so the reports will not be enough. You as a pediatrician, you have to learn how to read, how to see the images of an ultrasound. This is an extreme case. What you see there is the bladder that is absolutely distorted by the presence of a big fecaloma in a CT scan. And what are anatomically the effects of the constipation? As you can imagine, this big load of stools will cause compression in the proximal urethra and bladder neck, and this will create an alteration in the voiding phase. And compressing the bladder will alter the sensitivity as well. They don't feel they have the bladder because at some point they lose the capacity to feel that the bladder is full because it's stimulated constantly by the presence of this fecaloma. So what shall we do when we have a patient coming to the clinics with this?
Okay, so let's imagine a situation. We need to think about the history and the physical exam. That is really important. So the voiding diary, we're going to explain everything for you guys. The urine analysis and the ultrasound.
So
with poise voiding volume.
Okay, so you are not talking about any fancy
No,
investigations, things strange.
easy, basic.
With 4 things, you can manage patients.
You can have
right?
many information, yeah.
Very good.
More
So
than
let's
that.
go one by one.
Okay, let's start from the history, okay? Sometimes we need to expand the talk and understand the family history, understand the personal details, the lifestyle of the kids, the routine of that. Because if you don't understand the routine, how are you gonna deal with all the instructions that you're gonna give? Okay, so understand the void habits and the Bladder habits too. Okay, physical exam, it's really important, not just abdominal but pelvic floor too, but the fecal mass, try to palpate. And what else?
If you have the chance to have a direct observation, sometimes even the parents can bring you a video, or sometimes they bring you a video. So look how it's passing, and you see this interrupted stream, and it's not a full, or is good stream, or is weak.
Okay, so here we have the void diary. Okay, we can do 2 or 3 days. It will be enough for us, but try to make sure that they're gonna do correctly, and that diary represent the kid. Basically, the diary is something that you're going to complete for 2 days or 3, 24 hours. So since they wake up, since they go to the bed. Okay, so imagine the most important information is the time and the volume, and if they are having some leaks. Okay, if they have some incontinence. So with that information, you can understand the frequency and the amount of urine they are peeing. Okay.
And what is there that is showing in the upper part in the toilet?
Sorry.
What is showing there in the upper part in the toilet, just sitting in the toilet? Because this is a very important tool, more than. This is the what we give to the parents.
Yeah, okay, yeah, we give this because it's always, for me, it's clear enough.
For us,
yeah, but clear. So we give this from the patient, so it will be the life easier. They're gonna just sit and they're gonna measure the mLs. Okay, sometimes we can give more than one to make sure that they're gonna complete correctly, and make sure that they're gonna do that during the weekend, because you're gonna have more information.
Yeah, this is important because sometimes they assume that they can do every day and they miss the hours of the school. And then you will miss part of the information, at least half day. And lastly, we are having even apps helping the families to do this. Instead of doing in a diary, in the paper, they can do it in a specific app that is done for this purpose. The urinalysis is because urinary tract infections, even low urinary tract infections, can alter the bladder dynamics. Specific gravity is useful for the management of some conditions, and we'll talk about this. And of course, if you have a patient with diabetes, they will have polyuria. And the polyuria can mess up as well the clinical situation. And you have a bad wetting because he's managing high volumes. In the ultrasound, you will see bladder volumes to see how much is the bladder, and should be measured before and after that the patient pass urine. If there is any anatomical malformation that can lead for incontinence, principally if you have a duplex kidney, but I will not go into there, and if there is any thickness, increased thickness in the bladder. With all these things, we can start putting the patients in slots.
We're gonna try.
Okay. So, and which are them, basically, that we can very schematically talk about?
Okay, so let's try to think the moment that the bladder is getting full. Normally, the problem at that point can be the overactive bladder. The detrusores start to contract for a long time. So you can have this first one, overactive bladder, okay? And the moment that you're trying to eliminate all this urine, you can have the dysynergia, okay, that they call the dysfunctional void. You can have the underactive bladder, so the detrusor is not working very well, or the child just decide to hold, and they have problem to try to pee because they just want to enjoy the life. Okay, and the other hand, we can have the BBD, that's mean bladder and bowel dysfunction. So you have any urinary symptoms associated with the constipation, and you can have also the primary enuresis. Okay, it's important to just make clear we have primary and secondary. Primary means that since they was born, they still having that wettings, and they never stay like more than 6 months dry. Because if they stay 6 months or more time dry, it means that they have the control and something happened that they lose this control, okay?
So it seems easy then. It's easy. We put the pieces in the boxes, and then you can say, okay, primary nocturnal enuresis has this, and that. The lazy bladder has this, and the other thing. And easy. You just fill the boxes, and then you will have the last column that is not here. That will be the treatment. But I think that in life never happened like this. And we usually have all the things messed up, mix. Nocturnal enuresis together with some components of lazy bladder overactive and dyssynergia, right? That's the problem. And that's why we should not think like in boxes. We can use the boxes to have an idea, maybe, but then we have to see the patient. And that means you need to spend a lot of time. And that's why whenever we have a patient like this in the clinics, it messes up the clinics. So what we are proposing you here is basically to think dynamically. Keep in mind all these scenarios. Keep in mind which is the normal mechanism of function, the anatomical elements that are involved on this, and then apply to your patients. But you need to spend good time. And let's see a couple of cases where we can start applying these things. Okay. So we have Aisha, 7 years. And she went to the pediatrician, and Dr. Talia, the pediatrician, say, "Oh, everything's doing, no, it's okay, but she's having recurrent infections." With fever? No, no, without fever. First point, fever, no fever, differentiates between high and low urinary tract infections. And this you have to keep always in mind. When you have with fever, it's pyelonephritis, without fever, it's cystitis, low urinary tract infections. So then the pediatrician asks, "So, Aisha, how are you going to the toilet?" "Oh, okay, just no need to run.
Normal life.
Yeah, no bad wetting.
No incontinence. No bad wetting.
How is
normal.
it? Okay.
Normal too.
So that's why she said, okay, hold a second. What means normal for you? So what type of stools? And then you use a chart.
So she told like number 2 and number 3.
Okay.
And to say that more, sometimes 3 days you go to the toilet or more. So imagine a child with 2 or 3 stool, the characteristics of the stools with this.
So it's not normal, it's constipated.
Normal. It's normal for her, but it's normal for us.
Okay, so first point, it's constipated. She was saying no, remember. Second, how many times you go to the toilet, Aisha?
Yeah, she's not sure because nobody knows how many times you go to the toilet because we don't think about it. So she said maybe 4 times, but not sure. That's why we give the diary, okay?
But one thing that can start to give you an idea. So Aisha, we ask her, do you go to the toilet in the school?
Yeah, she don't like it.
No, I don't like it. And in the afternoon, I'm playing with my sister.
I prefer to enjoy.
Yeah, of course. And then the pediatrician asks for an ultrasound and to fill the void in diary. And what is the first thing that shows the ultrasound is that because of her age, she should have 240.
Yeah.
But how many has here? 340.
So
wow.
More than her age.
Yeah, it's a lot. And once she passes urine, 80 ml are still there.
Inside.
And look how many times she goes to the toilet in a day.
So you get shocked. And you ask, Aisha, for sure that you just go, you complete correctly? She say, yes, yeah, it's right.
And she's very interested, right?
Yeah.
So where will you put her here? We have these 2 elements, right?
Yeah. Okay, she don't have incontinence, she don't have urgence, but she hold. She don't like to go to the toilet at school. The diary, it's clear that she go just 3 times. She passed for 3 hours, and she also have constipation. So we can, if we can put in a box, we can say that she like to hold, she's a holder, and she have BBD.
Exact. So
we decide to,
yeah,
Dr. Talia decided to give some instructions for 2 months to see, and repeat the ultrasound and the diary to make sure that she's following how she's now going. So let's think about Aisha. Aisha, don't don't pass more than 3 hours to urinate, okay? It's important to make sure. How we can do that? We can try to put alarm. She can try to base on the prayer time, okay? She try to not pass the time to void, okay? Drink a good amount of water. Make sure that you have a butter, that you're gonna drink everything. If she wants to go to the toilet, just go, don't hold, don't wait for the next feeling, okay? Try to find a good position. What does mean a good position? With the support for the feet, clean toilet, try to make comfortable, relax without hurry. Sometimes the patients are with the phone at the toilet, or they just want to go fast because they want to enjoy. It's important to try the double void. It means that they're gonna pee, take a little bit more time in the toilet, then try to pee again. And also try to treat the constipation. I think it's the first one.
Yeah, maybe in her case, yes. So here are two very important concepts. That is what we call the time voiding. That means go to the toilet a specific time, even without the stimulus to go to the toilet. And the second one is a double voiding. Double voiding can be during the same time that they are sitting in the toilet to wait a little bit more, or you can bring to the extreme. Let's say they go outside of the toilet, 5 minutes, come back. And sometimes when you ask for a diary of this, they come to you saying, doctor, after 5 minutes I went and there was still water, still urine inside. So, and this is what happened with Aisha 2 months later.
Yeah, and one more important thing, try to make sure that the child is motivated. You can try to talk with the family to do something at the end of the month that she's gonna like to do if she followed the instructions, okay? So after 2 months, see what happened. The capacity is better, so it's smaller, okay? Based on her age is good, okay? It's not as small than normal, okay? And the ultrasound demonstrate the bladder is the capacity is getting better, and the post-voiding volume is reduced, okay? So that is a perfect case, no? You give some instructions for 2 months and she back.
Yeah, although you have to keep an eye on her, because if you see in the diary, the volume is very good in the morning, but along the day it tends to go down. That means that the family has to be aware that she has to persist on this. And let's imagine that she comes with this, and you see this sign, and you say, it's still not perfect, and she's still having some things. So what else can we do?
Yeah, because sometimes it's not going to work. This is the perfect world, no? It's the best idea. So give instructions and get better. Sometimes works, sometimes not.
So we can go to the more advanced investigations. Yeah. And this is the first line, and I would like you, Ananda, to explain what means this curve.
Okay, so this is the normal bell shape. Okay, so this is the normal flow expect for the child. So pay attention on the EMG. So
what is the EMG?
EMG is 2 stickers that we can collect the energy of the pelvic floor during the moment to pee. Okay, so this is the normal one.
What they measure?
What I measure, the energy and the contraction of the pelvic floor.
Ah, okay.
Sorry. Okay, good. So here we have the activation before. So they are sit in the toilet, the muscle is still holding, is still contraction, so you can see the activate, and suddenly the pelvic floor decide, okay, I want to pee. And the pelvic floor relax, and the detrusor contract, and the flow happen. Okay, so that is the normal shape. And then when you stop the flow, the muscle of pelvic floor contract again.
So these are some examples instead of abnormals, okay? And it's very clear in the first one that C, how it's showing that the muscle never relax. And that's why you have this interruption, right?
Yeah, exactly.
Okay.
Yeah, the flow, it's a relation by the volume and the time. So that's why you have this curve, okay?
Mm-hmm. So for sure, this uroflowmetry principle, if you associate with electromyography, is an excellent exam.
Yeah.
But again, it's a single event. So you need to put in the middle of other things.
And you also can try just to do a normal flow. If it's something wrong, you can try to do the flow with MG.
Okay, okay. But these are things that are available just in our lab, right?
Yeah.
Okay. But let's imagine that you say, no, but I want something more. And I have received many referrals saying for urodynamics. And I want you please to explain what means for a person to do a urodynamic study.
Okay, so urodynamic is one complex exam. The uroflow is one of the parts of the urodynamics, okay? The uroflow is non-invasive, but the urodynamic is invasive. So that means that we need 2 catheters inside the bladder, okay? 1 in the rectal part and 2 stickers in the pelvic floor. So imagine this child on this situation in a room with catheters, with stickers, with liquid going inside the bladder is too uncomfortable. So we have a specific indication for this kind of exam. basically if a patient who doesn't answer for the treatment, so you try many things but is still having the symptoms, and the patient have neurologic problems. Because this study make a whole information, how is the pressure inside, how the bladder works, how the volumes, how is the capacity, how is the abdominal during the moment. So they have whole information.
And you say something very important, because when you say about the abdominal pressure, so we are measuring the bladder, that is a cavity that is inside of another cavity that is the abdomen. So if you have a child that is complaining and coughing and moving and
not going to work.
The abdominal pressure will impact into the bladder. Exactly. So it's like looking at through a very dirty glass, yeah. Right? So for this reason, any children with voiding dysfunction or with any incontinence, is not all of them are candidates for urodynamics. Yeah.
So you can have enough information. You have a diary, a flow, and ultrasound. That would be perfect, and a diary. So with this information would be.
Oh, definitely. And let's see what happened in this second case of our friend Mohammed, that is 10 years. And he had an appointment because he's still wet in the bed every single night. And you see on the top left, and the top right, I'm sorry, you see the diary of the wet and dry nights. And you see that the sun is rarely seen. It's always cloudy, raining. And yes.
Yeah, no, according to the mother, he's a deep sleep. Okay, so she tried to wake up him, but it's hard. He don't wake up easily. So also the father have urealysis too. That's why, as we told you in the beginning, the history of the family and of the child is important. Okay, so the situation it's causing many problems of the family. And they have many argues about that. And Mohammed is feeling bad about that. So the self-esteem is really low. He's 10 years old. He have small brothers that stopped to have bad wettings, but he's still on this situation. And the mother is really tired because she needs to wake up twice in the night to go to the toilet, but it's not working. It's not enough.
We do the usual ultrasound and the usual investigations. And the first thing that comes out is that his voiding diary is
normal,
perfectly normal. He has a good frequency, good volumes, no accidents during the day. The urinalysis is showing low specific gravity and no glycosuria. So in this case, we can put him directly
in the box of urinalysis.
Exactly.
Yeah, and primary because he always was peeing in the bed.
Exact. So this case is simple, straightforward.
Yeah, but sometimes you can have like combined situation. You can have Aisha case with Mohammed case. So
yeah. So which could be the treatment for this primary nocturnal urealysis?
The basic thing is make sure and clear for the child and the family that is completely common. The child is not the only one. I always say nobody go outside and share that you're still peeing in the bed. So what do you think? Maybe your colleagues is still peeing in the bed and they don't share with you. So make sure that they feel better and comfortable about this situation. And
yes, some initial measures.
Yeah.
Some initial measures we can start doing.
Exactly.
Respect the fact that the father had the enuresis was very significant, and I found that usually the child respect the same age of resolution than the relative that was affected for.
Yeah.
And then the decision of whether to treat or not, it depends basically on how much the child is interested to do it.
Yeah. So basically you can give some instructions. So try to reduce the amount of liquid during the evening. Okay. So drink a big amount during the day. Make sure that he's hydrated. Try to, at the dinner, not eat salty food or soup or heavy, spicy food. Try to have the dinner 2 or 3 hours before the bed to make sure that they're going to eliminate everything. Go to the toilet before bed. Don't wake up the child during the night. This is a polemic thing because sometimes not going to be effect. And the other point, the mother is going to be tired because she wake up during the middle of the night to wake up the child. And the other important thing, do not punish. Okay, sometimes we don't talk about that, but we don't have just physical punish. We have verbal punish too. So make sure that the fathers understand that it's a common situation in the child. So try to not punish.
So there are specific treatments for primary nocturnal urealysis. We briefly talk about them. And the most common quicker and easy to manage is the desmopressin. That's this analog of the desmopressin. Yeah, the question is that some people get scared about the word hormone, so they don't want to give it. And then we need an alternative that is the alarm. And the alarm is based on what Pavlov discovered about this conditioning. And that means that the alarm has the useful to wake up the child in the moment that the child that passes urine. And this can lead to a specific conditioning of the brain, so they start to feel during the night that the bladder is full, while before they were not feeling at all.
Okay. And one question frequently of the parents is, okay, what would be the difference from the alarm and the difference put alarm in the phone or wake up the child? The difference is the alarm, the bedwetting alarm, is going to alarm at the time that the first drop of urine goes out. Okay, so the moment that the brain doesn't wake up the child, so that is the difference. So it's not gonna work if you put alarm in your phone, because they're gonna alarm in the exactly moment that they used to go to the toilet. They need to go to the toilet.
And you need then a family and a child very committed, because they actually have to wet the bed.
And the other and the other point is not for everybody the alarm. You need to make sure that the family is motivated. You need to make sure that the child is sleep alone, because imagine if he sleep with the other brothers or sister, everybody at the house going to wake up, okay?
Because they are the last one to wake up.
The last one, they had deep sleep.
Oh, very. Usually they have. So I think that we are finishing very early respect of what is supposed to be, but we would like to leave you with this final slide that is maybe the center of our talk. And is, don't try to make like a recipes. You have this, and this, and then this. But you have to put all the things together and think about your patient and tailor the diagnosis and the treatment on your patient situation. And to know that, you need to know how the bladder works. Without knowing this, it's very difficult. And it's not so complex. It's very simple. Two sphincters. One works automatically, the other one works commanded by our brain. And most of the time, the children, they hold the urine. And when a family comes to you saying the child is not able to hold the urine, usually it's exactly the opposite. And that's why you need to spend the first hour of your consultation to destroy whatever they think they know, and the second half an hour to build the new things. Time consuming, you need to spend a lot of time with your patients. Whenever you see a wetter, don't try to make it in 5 minutes. You will fail. Yeah. Or maybe the patients will go, but will go and they will come back with the same problem again. So again, it's just a question of friendship, good collaboration, even when you feel you are one against the other. But we are not like the sphincters fighting one each other, no. But we try to work together. We're open for any question that can be. Thank you very much.
Thank you.
This is a fantastic and dynamic presentation. I really like the presentation very much, and it tells about the synergy that the teamwork can make a difference for these children. It's a very annoying problem for families, and it is very for the pediatricians also. They feel they want to help, but again, the understanding of the basic principles are very important. My question is, and my comment is, in certain situations, the degree, and I want to alert it to the pediatricians, that the degree of the dysfunction can become severely affecting the kidneys upstairs. That the degree of the dysfunction of the bladder, and we all believe that if the bladder is not healthy, at some point the pressure will be transmitted to the kidneys in certain patients like Hinman syndrome and non-neurogenic bladder. That at some point the bladder behaves more of a non-neurogenic, although it is and as a neurogenic, although it's not neurogenic. So if you can shed some light on the Hinman syndrome or neurogenic bladder to the audience will be important.
Yeah, I mean, all these basics works as well for the more complex situation, like either spinal bifida neurogenic bladder or the neurogenic bladder. We should not suspect Hinman syndrome in each bladder, okay, or each patient that we have coming to us, because otherwise we go crazy. It's an uncommon scenario. But let's say if we keep the same principles of how the bladder works, we'll be able to manage from the simpler, wetter, as we call them in the clinics, to the more complex spina bifida patients. The neurogenic bladder is basically a situation where you have a child that has no anatomical defects in the spine and presents as a neurogenic patient with either not able to hold the urine, because as well there you can have combinations. Even in the neurogenic bladders, you can have some it's a combination of sphincter and detrusor. So if you have a patient, you can have a patient with weak detrusor and strong sphincter, then they will hold the urine for a long time. You can have exactly the opposite, very contracted detrusor but weak sphincter, and then they will leak all the time. So this is variable and it's absolutely different from one patient to other. The dangerous scenario is when you have the detrusor that is contracted and sphincter contracted. Then you will have, for sure, you have some upwards problems. Pressure alone is discussed if this can cause a damage or not. What for sure can cause a damage is infections in the kidney. So if you have a patient, even with just constipation and some bladder dysfunction, but coming to you with recurrent pyelonephritis, you cannot just say, okay, fill the diary and come back. You need to be a little bit more aggressive with these patients. But this is very tailored to that situation. It's exceptional. I remove it just for a question of time, but I had slides of patients with constipation and demonstrated vesicoureteric reflux. Once the constipation was solved, reflux was solved as well. This is for you.
Yeah, no, normally the spicy food or the salty food or chocolate, this kind of things make the detrusor inside of the bladder more irritate. So make the bladder more overacting during the night. That's why we try to take some kind of substance or liquid like Coca-Cola, all these things that make the detrusor more irritate, the spicy food too. But always you can try to manage it, okay? It's not mandatory, but if you, that's why you need to understand the reality of the family, okay? So you need to do some small changes, okay? You see?
Talking about child abuse or emotional disorders. I'm a urologist.
Okay, yeah.
No, I
it's
mean,
hard though, yeah.
Yeah, I mean,
Yeah, I think we need to discuss that honestly. Like we don't talk about that. We know that we can have some effects of sexual abuse and the incontinence, okay, and the emotional problems. Honestly, it's something that go directly. Okay, I can see that frequently on the appointments with the patients. That especially, for example, when they have some new brothers in the family, when they change the school, when they have someone in the family dies, so that things can go directly for the urinary symptoms. And one hypothesis for that, for the emotional problem, is the last thing that we use to communicate with our parents, it's the diapers. So we start to eat, but sometimes we still disconnection with the diapers. So when you leave the diapers, you don't need more this kind of connection with your parents. You're more independent. So sometimes you try to take again this connection with the urinary symptoms.
Yeah, there was a request regarding to show the PVR and volumes.
Okay.
Let me just go back to the previous one. It's one of the firsts.
Yeah. One more. What's the first one?
Yeah, I think it's very first one.
That
That
okay.
one. Okay. This can be useful, and keep always in mind, because this is very useful to understand whenever even you see a diary, and if you see low volumes, can be because there is a high PVR, or the problem is that one. You can have a patient that is leaking, can be either because has overactive
Yes.
or underactive. And
Or
both,
sphincter problem.
exactly, and both will give you the same symptom. So
Yeah.
that's why you need to investigate very clearly all
Yeah.
these things. I don't know if there was,
Yeah.
I'm sorry, Amira.
So, but there are, some of our clinics are very pediatrics with the bedwetters.
So we don't want to send them all to you guys, and we are very happy to treat those with the simple primary nocturnal enuresis using the desmopressin and and the alarms. But we're talking about the ones who are like more dysfunctional, those that have the urgency. When do you want us to send them to you?
Let's make it clear.
Okay.
If you send a patient with a voiding diary and with the constipation resolved, you are beyond the half of the way for us. And you save us at least 2 appointments because we are crampy as well. But for sure, I mean, if you manage the constipation and you have a voiding diary, at least,
It will be helpful. Yeah.
this is, believe me, this is, I think that you will start learning and you will send less and less because you will start, the problem is for you as for us, these are frustrating patients. Let's tell the truth. Whenever you have one of them, say, oh my gosh, another one. And they come always 1:30 and beyond.
Yeah.
When you are already tired, you are already exhausted with the very crampy clinics, this is the moment that they arrive.
Yeah.
I'm seriously thinking to open a clinics from 3 p.m. onwards, only for this kind of patients with slots of 45 minutes.
It's going to jump over.
I don't want, because
yeah.
I'm already tired. Believe me, I have clinics now starting at 12,
Yeah.
and I know that the patient wants 32 and 2:30.
Yes, correct.
And the point too is sometimes they came, we think that is monosymptomatic enuresis, but when you open and start to investigate, you have day symptoms. And believe me, you're not going to get better in the 9 symptoms if you don't treat the day symptoms. For example, one case of overactive bladder, you have a small capacity. So if you have small capacity, don't think that at the night you're going to have a good capacity, because if you don't have during the day, you're not going to have during the night. So you need to treat the overactive bladder, you need to treat the capacity to get better the night. So one important question is, okay, you have bedwettings. How many times during the night you have? Okay, it's a big volume, it's a small volume, and it's in the beginning of the night, it's at the beginning of the morning. So you can have this information that it's important thing to have idea about the case of the patient too.
So, but to summarize, if you tell me which patients you want to see, I will say the patient after treatment of constipation and with the regular voiding during the day, you still have a problem.
After the instructions,
then we can intervene. But
Correct.
we need first to clean the constipation and the patient that is frequent, that is holding the urine.
Correct. Okay.
So with these 2 things clear, believe me,
Yeah.
we save at least a couple of appointments.
Thank you very much. Okay.
And the other thing the families have to know, that the frustration that they have is because it takes a long time, because maybe they have expectation that 3 sessions and it's done.
Exactly.
No way.
Yeah.
No way. Takes a lot of time as well, the treatment.
Absolutely.
I don't know if you notice, I never use other than desmopressin, and in a very specific
I was going to ask you about oxybutynin.
Oxybutynin.
A lot of people.
A lot of people is using oxybutynin
Yeah.
in patients who are holding the urine. Then you make the things even worse.
Correct. Okay.
Because oxybutynin tends to reduce the contractility of the bladder. So the post-void residual urine will be higher. So I'm very, 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 cautious in the use of oxybutynin. I'm using rarely.
Okay. Only if you have overactive bladder, right?
Yes, and once I'm completely sure that the patient is going to void frequently and not having post-void residual urine. And the constipation is treated, because as well the oxybutynin can cause constipation.
Yes,
Correct.
exactly.
Okay.
And for overactive bladder specifically, with Ananda we have another tool that is the electrical simulation of the perineal, of the sacral
Nerves, yeah.
nerves. This
Okay.
is through small pads, adhesive pads. You can deliver a very small amount of current, and this helps. But again, you need a diagnosis. That's the problem. If we don't diagnose, we cannot treat.
Yes.
Correct. Thank you.
I think that we went beyond the time. Yeah.
Awesome. I think we have 5 more minutes and we're done.
I have one question.
Yeah.
You have
No,
one
no,
more
I'm
question?
done.
Oh, okay.
So Sharda is asking about normal volumes and PVR. And there, can you explain any effect of early toilet training that is required here for school by 2 years of age?
Yes, that can be a big problem. Okay, so sometimes to put the kids in the school, you need to take the diapers. So you go for this anxious, sorry, you go for this anxious moment and pushing the kid to stop to use the diapers, and obviously you can cause some problems. So imagine like a kid that the mother is like trying to take the diapers and they decide, okay, I cannot go to the toilet, so let's hold, and they can have like detrusor problems. So if I'm not wrong, they have some articles already showing the early training, toilet training, having relation with the dysfunctional problems, bladder problems, and in the future as adults too. And
Yeah, I mean, sometimes some of them became, because they don't, there is some, the water clothes can become, they have a fear of it. They don't want to sit there. And to go for even either stools of urine, they hold until it comes out. I mean, they start to leak. So yes, there is an avoidance.
And one question frequently is, what is the best moment to take the diapers? So I always say that we have 3 stages. Okay, the first stage is the child doesn't feel before, doesn't feel during the moment that they are peeing, but they feel after, when the diapers is full and heavy. So they say, Mom, Baba, I already pee. Okay, so that is the first stage. So don't take the diapers now. They are learning. Second stage, they are peeing. So the moment that they are doing, they say, Mama, I'm peeing now. So they cannot feel before, but during the moment they realize that they are peeing. So don't take the diaper, it's not the best moment. And the third stage is, I want to pee. And that is a physiologic urgency, okay? So they want to go to the toilet fast. Sometimes in the middle of the way, they're gonna lose urine. And that is normal and expect because it's a physiologic urgent, okay? So that is the best moment to try to take the diapers. What you can do, try to take for some periods at home and try to deal with that. You're gonna have some accident that is expect, can happen, but that is the best moment. That is the signal that you can take the diapers.
Because we are almost there. Just 2 minutes. Let's see. Please, can you help answer? No, this one. School in Qatar requires toilet training at 2 years of age.
Yeah, hard.
I'm a urologist.
Okay, thank you very much. Okay, it was really a great educating and entertaining. I really like the duets that you've done. Okay, so thank you so very much for the information, and thanks for the audience for attending. Okay, thanks everyone. We conclude.
Very, very.